Good morning, everybody. I would like to call the meeting to order. My name is Dan Elliott. I'm the chair of the CTAF committee. And to my left is Paul Heidenreich, who is vice chair. We're going to be talking about two new technologies for the management of heart failure today. And I would like to say a few words about CTAF, the California Technology Assessment Forum. CTAF is a core program of ICER, and as such reviews ICER-produced evidence-based reports on the effectiveness and value of healthcare services and provides a public venue for discussion among all stakeholders. CTAF's mission is to help patients, clinicians, insurers, and policymakers interpret and use evidence to improve the quality and value of health care. CTAF's vision is to create a future in which collaborative efforts to move evidence into action becomes the foundation of a more effective, efficient, and just healthcare system. I want to say just a word about conflict of interest or relationships with industry. I think in your packet you will see CTAF's policy on conflicts of interest. We have polled the panel, and Dr. Heidenreich has participated in some value studies. He has no financial conflict of interest, but since he has participated in some of the studies of value of both technologies, he will recuse himself from the discussion and voting on the value aspect of those two technologies. So I would ask all of our speakers to declare any conflicts of interest, if they exist, prior to their remarks. I'd like to introduce Karen Shore. Dr. Shore is Program Director at the Institute for Clinical and Economic Review, ICER, and a leader at CTAF. She obtained her PhD in Health Services and Policy Analysis at UC Berkeley. Karen?
So welcome, everyone. We're delighted to have you here for the CTAF meeting, folks in the room as well as those on the webcast joining us online. I just wanted to take a minute to thank our funders, the Blue Shield of California Foundation, the California Healthcare Foundation, and as of this summer, the Laura and John Arnold Foundation. So thanks again, everyone, for being here. Just a couple logistic items. Please put your cell phones on vibrate if you haven't done that already. And then restrooms are outside and down the hall past the registration desk where you came in. And help yourselves to folks in the room, obviously, coffee and breakfast items that are outside the room. So for the panel members, in your packets you have the materials for the presentations, the voting slides, and the worksheets and other materials, the conflict of interest that Dan mentioned. And then for the audience, you all have the agenda with a list of the policy roundtable participants as well as the CTAF panel members. That's on the second page of the agenda, the voting questions, and then some key tables from the report. So this is the agenda for today. Soon we'll be hearing from Dr. Dan Ohlendorf and Dr. Alex Sandu. They'll be presenting the evidence for the day. We'll have about a 45-minute period for public comments from 11:20 to around noon, plus or minus. We'll break for lunch and have 45 minutes. So the panel, the advisory board, and the policy roundtable participants will be next door, and the audience will just have lunch outside this room where the breakfast is now. And then we'll have voting this afternoon. The panel will be voting on clinical effectiveness and value. And then there will be a policy roundtable discussion, followed by some final remarks by the panel, and we'll wrap up around 3:45. So for folks who are online or interested, the slides are available at the website that is shown there. It's http://tiny.cc/CTAF-CHF. So please go there and download the slides if you're interested in that. So actually first going to introduce Dr. Judd Weisberg, who's going to be facilitating a lot of the meeting today, and he'll be first setting the stage for our discussion. He's a gastroenterologist and joined ICER last year as a senior fellow. He had a 30-year career at Kaiser Permanente, most recently as Senior Vice President of Hospitals Quality and Care Delivery Excellence, and was also Medical Director of the Medicare Advantage Cost and Prescription Drug Plans.
Thanks, Karen, and welcome everybody. We're going to demonstrate how the CTAF program works, and it works very much like the other core programs of ICER, the Institute for Clinical and Economic Review. We pride ourselves on the systematic reviews and the rigor of our analysis, which you'll see presented by Dr. Dan Ohlendorf shortly, as well as pairing that evidence review with economic analysis, which will be presented by both Dr. Alex Sandhu and by Dan again. After that, we will be asking our panelists who are assembled at this table, whose bios you have in the program, about their judgment on the clinical value of the interventions to be discussed, the economic value, and the overall health system impact, budgetary impact, and thus a value-based kind of price benchmark, which is the extension of our evidence review into the policy realm. We'll be talking about congestive heart failure today, a condition every clinician has encountered. When I was an intern, we treated congestive heart failure with Lasix and nitrates, and it's my understanding from reading the evidence review that that's still pretty much the case, Paul. So we have to make some progress in this. We'll hear briefly about some of the devices, implantable devices, which are now used in the treatment, as well as a new agent that seems to hold the promise for improved health. We will hear the evidence about that and review that carefully. In addition, we will be presenting the methods of our economic review, which are fully outlined in our full report, for your edification and discussion. And with that, I'd like to jump right into it and invite Dr. Dan Ohlendorf, our Chief Scientific Officer, up to the stage.
Thank you, Jed, and good morning, everyone. So as Jed mentioned, in terms of the choreography, I'll be presenting information on our review of the clinical evidence, and then I'll step away and let Dr. Alex Sandhu talk to you about the care value modeling that was done, and then I'll jump back up and bother you about budget impact. Okay. So I have no conflicts to disclose, but I do want to acknowledge the efforts of other members of the ICER review team, Elizabeth Russo, Patty Sinnott, and Karen Travers, who were instrumental in helping to conduct the evidence review. So as Jed mentioned, this CHF, or heart failure, is a common problem, and it's a big and growing problem in this country. The disease itself is marked by fluid buildup due to inefficiency in the heart muscle as it tries to pump out blood. The current estimates suggest that over 6 million individuals in the U.S. suffer from heart failure, and there's a high degree of morbidity associated with it. Morbidity is often measured using something called New York Heart Association class, and classes 1 through 4 are dictated or are classified based on the symptoms present in the patient and how those symptoms are affecting physical and other functioning. So they go in severity from 1, the lowest level of severity, to 4, the most severe form. The disease itself, though, carries a high degree of mortality as well. 5-year rates of mortality of 40 to 50% are similar to that for many cancers. And there are also high rates of hospitalization and repeat hospitalization, as well as intensive outpatient care. So it's not only a clinically serious condition, but also very expensive to treat. Its prevalence is due to the fact that many diseases that have an effect of weakening of the heart muscle, coronary artery disease, hypertension, et cetera, are also very prevalent. And so that's why it's such a common condition and a growing condition. So we evaluated the evidence on 2 recent interventions for heart failure. The CardioMEMS heart failure system, manufactured by St. Jude Medical, which is a wireless sensor implanted in the pulmonary artery. The pulmonary artery is often, or pressure in the pulmonary artery is often a correlate of worsening CHF, and in fact, increases in PA pressures have been known to signal the worsening of the condition before symptoms are actually present. In this case, the device is a permanent implant of a sensor in the pulmonary artery with pressure readings that can be made daily that are then transmitted to a secure online database where treating physicians can track pressure data and make necessary adjustments to treatment based on those readings. The device was approved by the FDA in May of 2014. The other intervention is a pharmaceutical, a combination therapy of the neprilysin inhibitor sacubitril, which has the effect of maintaining fluid balance and the existing angiotensin receptor blocker, valsartan, which is used to lower blood pressure and improve hemodynamics in patients. And this was a recent approval, just approved in July 2015 for the treatment of heart failure. So a brief overview of our methods. We did separate evaluations, this is important to note, separate evaluations of the comparative clinical effectiveness and the comparative value of the two interventions. So this is not a review that involves any attempt to try to compare the two together. So these are separate evaluations of CardioMEMS to the existing standard of care for monitoring and Entresto for the existing standard of care to the existing standard of care for treatment. Our review is based primarily on phase 2 and 3 randomized controlled trials, but we accepted all evidence that was relevant to the two interventions. And our target populations really followed the FDA labeling for the two. So for CardioMEMS, this is adults with class 3 heart failure who had been hospitalized in the prior 12 months. That also matches the entry criteria for the major trial I'll be talking about. For Entresto, it's a broader population, adults with classes 2 to 4 heart failure and reduced ejection fraction. Ejection fraction is a signal of the efficiency of the heart muscle in pumping out blood. The normal heart pumps out anywhere between 55 to 70% of blood volume on each contraction. So a reduced ejection fraction of 35 to 40% is a signal of a more severe condition. In terms of comparators, for CardioMEMS, this is typical management or typical monitoring based on patient signs and symptoms and treatment changes in reaction to those, to changes in signs and symptoms. For Entresto, the comparator in the major trial that I'll be talking about for that intervention is ACE inhibitor therapy, which had been previously demonstrated to reduce mortality in clinical trials in patients with heart failure, and so was felt to be the standard of care for the treatment of patients in this group. Outcomes of interest in the evidence review included mortality, hospitalizations for heart failure, and emergency department visits for the treatment of heart failure, measures of quality of life and functioning, as well as heart failure symptoms, and complications of the device, as well as adverse events related to drug therapy. So let's start with the evidence on CardioMEMS. So there are a couple of studies mentioned in the full report of the evidence review, really just two, the CHAMPION trial, which I'll be talking about in detail, and a small case series, which is mentioned in the report, but I'm not going to discuss here because really the evidence that we need to be discussing in detail comes from the CHAMPION trial. So CHAMPION was a single-blind RCT, so patients were blinded to the form of the device they were receiving, but physicians were not, involving 550 patients. So the device was implanted in all patients in the trial, but PA pressure data readings were transmitted only in the patients who were in the treatment group. In the control group, the transmissions were blocked. So again, the device was implanted in everyone, but the actual PA pressure data was only made available to treating physicians in the treatment group. So again, class 3 patients who'd had a prior hospitalization within 12 months. There was single-blind follow-up for 6 months in the trial, and then the blind was broken after for additional follow-up. And I believe for all possible outcomes, mean overall follow-up is actually 17.6 months, but in the primary publication of data, unblinded data were reported at a 15-month time point. And I'll talk about, in terms of the outcomes we go over, which were measured at 6 months and which ones were measured at 15 months. We received some public comment about this, so we wanted to make sure we clarified. This study was powered to detect differences in the number of heart failure-related hospitalizations at 6 months. There are mortality data reported as well, but this was not a primary outcome of the study, and again, the study was powered to look at hospitalizations. So in terms of those results, for heart failure hospitalization at 6 months during the blinded period, there were a total of 84 hospitalizations in the CardioMEMS group versus 120 in the control group. That translates into a hazard ratio of 0.72, a statistically significant difference, and a number needed to treat, or a number needed to monitor, I guess we'd call it here, to prevent one hospitalization of 8. So 8 patients would need to be monitored with CardioMEMS to prevent one heart failure-related hospitalization. This measure was also repeated at 15 months, so again, after the blind was broken, and the differences widened a bit in terms of the numbers of hospitalizations. Hazard ratio was 0.63 in this case. Number needed to treat was 4. Okay. There was also a reduction in the length of stay in hospital among those hospitalized in the CardioMEMS group, a little over 2 days versus nearly 4 days in the control group, a statistically significant difference. So as I mentioned, the study was not powered to look at differences in mortality. Mortality data have been presented separately in conference proceedings, but our focus was on the published literature, so we don't talk about them here. Mortality data were also presented separately to the FDA. But in terms of the published data, mortality was only assessed as part of a composite supplementary endpoint, and this was time to death or first hospitalization for heart failure. And over 15 months, this is the time point at which these data were presented, so again, with the unblinded period included, 107 patients died or were hospitalized in the CardioMEMS group versus 138 in the control group. A similar hazard ratio to the hospitalization data alone, 0.73, a statistically significant difference. In terms of quality of life was measured using an instrument known as the Minnesota Living with Heart Failure Questionnaire. There was a statistically significant difference at 6 months, the blinded period, but relatively modest in terms of its difference, about 3 points. There was not a separate measure of the proportion of patients who achieved a clinically meaningful difference, which is typically felt to be 5 points on this scale. But on average, the 3-point or so difference did not meet that 5-point threshold as well. The study was also powered based on an expectation that there would be no system or device-related complications in 80% or more of patients. And this endpoint was achieved in actually 98.6% of patients. There were, however, 15 serious adverse events noted. 8 were related to the device or the broader CardioMEMS system itself, and 7 were related to the implant procedure involved in putting the device in. Bleeding events were the most common, 2 groin hematomas, 1 case of epistaxis, and 1 hemoptysis incidence. Device or system complications included 1 pulmonary thrombus during right heart catheterization, that's the implant procedure, 1 case of cardiogenic shock. There were also 3 hospital admissions related to anticoagulation requirements during the procedure. There were also some publications that we included in the evidence review that were, again, based on CHAMPION, but involved either pre-specified or post-hoc subgroup analyses. There was 1 publication or 2 publications that looked at the performance of CardioMEMS in patients with versus without pulmonary hypertension, and at the time of the implantation procedure itself. The presence of pulmonary hypertension can affect hemodynamic monitoring and readings, and also in patients with and without chronic obstructive pulmonary disease, COPD. And the reductions in the rate of hospitalization were similar across these 2 subgroups. The device is also approved for patients with both reduced ejection fraction as well as preserved ejection fraction. So in a growing number of patients with CHF, while there are signs and symptoms of the disease, ejection fraction, the efficiency of the heart pumping blood, is actually preserved in a growing proportion of patients. And so this subgroup analysis was also conducted over the full 17.6 months of follow-up. And you see that there's significantly, statistically significantly reduced rates of hospitalization in both patient subgroups. Performance looks to be better in those with preserved EF versus reduced EF. Preserved EF was a relatively small set of the overall sample. In this case, I think about 20% of patients. So the device, obviously, as I mentioned, is approved by the FDA. During advisory committee discussions, there were some controversies and uncertainties discussed. One of the key controversies is the fact that the device as used in the CHAMPION trial is not completely reflective of how it's going to work in clinical practice, where these pressure readings will be transmitted directly to treating physicians in cardiology practices. In this case, the communications actually went to study nurses, so at the investigator sites, who then transmitted readings to both physicians who were treating patients in the treatment group as well as in the control group. The intent of the communications was to convey that pressure reading data to make sure that they were able to see it and make treatment decisions based on it. But in some cases, the communications were much more detailed and involved recommendations for modifying treatment. And so in initial advisory committee discussions, there was concern about whether this device would actually work as it's intended in typical clinical practice, where there would not be, obviously, the availability of study nurses. So initially, the discussion between the FDA and the manufacturer centered around conducting another trial with a somewhat different design. But the decision was made jointly to have the manufacturer do additional analyses. So there were additional analyses conducted looking at the performance of the device after the blind was broken in patients who were in the former treatment and the former control groups, and found that the reduction in hospitalization did continue, but the characteristics of the patients in those groups after the blind was broken were somewhat different than they were at baseline. So there was a lower baseline rate of hospitalization, for example, at that point, and a lower rate of mortality. So there was concern about how reflective this really was. And that concern really remained throughout the deliberations. There was kind of a conclusion that there still is the possibility of the introduction of bias from this design. The extent of the bias is unknown. Initially, there was evidence suggesting a treatment by gender interaction. So the device appeared to have much better performance in men than women. And again, the manufacturer did some additional analyses, including both hospitalization and mortality in the outcome. Initially, the concern was just about hospitalization, and found no conclusive evidence of an interaction when both types of outcomes were considered. But the FDA is requiring St. Jude to do a post-marketing study looking at effects by gender in further study. Some on the advisory committee were also concerned that given the evidence of reductions in hospitalization and the increased risk of death associated with being hospitalized for heart failure, that there should have actually been, even though the study wasn't powered for this, there should have been an independent mortality benefit observed, and to date there has not been. Again, that's not how the study was powered, but that was a concern among some advisory committee members. Because of the nurse communication issue, the FDA is actually requiring a second study as well to look at real-world effectiveness in patients, obviously in the post-marketing setting, versus the effectiveness as observed in the trial, to see if there could be some conclusions drawn when that nurse communication factor is taken out of the mix. So to summarize, we concluded that there was moderate certainty of a small net benefit versus the usual monitoring of signs and symptoms. We concluded that the certainty was moderate. We had one phase 3 trial to work with, and We also felt that the magnitude of the benefit was somewhat uncertain primarily because of this nurse communication issue. And because of that, there's a small chance that the net health benefit could actually be negative. In further study, there may be a benefit in terms of hospitalization reduction that may not be as pronounced as in the initial trial. And then you have to weigh the possibility of harm, as remote as it is, relative to non-invasive monitoring in these patients. So that leads us, using the ICER evidence rating matrix, to an overall rating of promising but inconclusive. We are also obligated to think about other possible benefits or disadvantages of these interventions. And in this case, in some patients, there may be anxiety that comes from the implantation of a permanent device. In other cases, some patients may have reassurance from the fact that there is a device implanted that is monitoring PA pressure relatively constantly. So I can move on to Entresto. I'm not sure if I should take questions now. Looks like there already is one, so I will.
Dan, your conclusion was that there is a moderate certainty of a small net benefit and that the technology is promising but inconclusive.
Right.
When it comes to our voting, I assume we are not bound by your conclusions, but we can arrive at our own conclusions?
Absolutely.
Thank you.
So this was our judgment, but you should arrive at your own conclusions.
Thank you.
Christine?
Yeah, I have a question about the patients in the study and what happened to them. The inclusion for the study in the first place, really the only drug requirement was that they were on diuretics. So I wonder if the simple fact of the treating physicians getting information about the control group may have prompted more patients to be put on ACE inhibitors and beta blockers. And in fact, the CardioMEMS really is a fancy way of just alerting the physician to pay more attention to those patients than they would have otherwise, I guess is what I'm getting at, and getting them on usual care.
Yeah, so I think that one of the challenges we faced, and there was another publication that was pre-study results that described the protocol of the study, and we kind of exhaustively went through the FDA documentation as well. Other than sort of brief descriptions of how medical management was optimized in both groups, there was really not a great understanding of exactly how that was done. And in addition, whether there were other monitoring or disease management approaches used to try to prevent readmission in these patients. It was hard for us to be able to tell. So unfortunately, I can't provide any more detail on your question, but
Oh, thank you.
yeah.
Dan, did I understand correctly that there was no mortality analysis, or there was no mortality benefit, although it wasn't powered for mortality?
So that in terms of what is published, the only mortality analysis is as part of this composite endpoint.
Right.
Time to mortality or first
But
heart failure.
certainly they
hospitalization.
could separate out in that.
Yes, they can. And there have been separate conference presentations on mortality alone, and there was a separate submission of mortality data to the FDA. There was a nominal reduction in mortality with CardioMEMS, but it was not statistically significant in the FDA documentation.
Because obviously there's, at least in my mind, concern about the hospitalizations. It's a lot softer endpoint, and it is a lot due to interaction with treating physician or study nurses, and with the clear differences in study nurse involvement in the CardioMEMS arm and in the control arm. It really raises the question of, are we seeing a difference in study nurse or team management, which is certainly a known beneficial approach to heart failure, or
Right.
did it have anything to do with the monitoring? I would remind you, there aren't any studies that show PA monitors lead to improved outcomes in heart failure. So then why implanting a PA monitor, with all of the risks of implanting a monitor, would lead to better outcomes? It's not clear to me why we would expect it to, and
Right.
that makes me think it could be the study nurses.
Right. I expect, although I don't know in detail the protocols for the post-marketing studies, but I'm expecting that they would be evaluating mortality as a separate endpoint.
Right, but of course the post-marketing studies, I don't believe, have a control group.
I'd have to get more detail.
That's
I can
what
look up more
that's
detail
how I
on
read
that.
it in the material you gave. It just said it was an observational, I think
That
it's a
there's one
registry
observational
of
study that's
people that got
supposed
it
to
implanted.
basically look at the trial data as a historical control, but the other data that primarily is supposed to assess the possibility of interaction may actually have a comparison group. I'll double check and let you know. Jeff?
So one of the things that was interesting is they also had a shorter length of stay in the hospital, and as Rita just pointed out, we know that PA monitors in the hospital, that was something that was in vogue when I was in training and sort of fell out of vogue. Yet there's a shorter hospitalization. Was there actually active involvement in altering the hospitalization, or was this going to outpatient cardiologists? In other words, why is there a shorter hospitalization in people that had the device?
I'm not sure that there was any explanation given for this. So the data were transmitted on an outpatient basis. So it wasn't as if there was more information provided during the hospitalization itself.
Dan, I would like to point out that there will be a point in our meeting where there will be public commentary, and the manufacturers will be able to help us understand some of these nuances.
Sure.
Along those lines, the length of stay, was that overall length of stay, like hospital days total over the time period, or was that
I believe
per
it was
hospitalization?
length of stay per hospitalization. Jerry?
I'm afraid I'm probably repeating Dr. Redberg's question, but I just want to be sure on this point. You said that the study wasn't powered to compare mortality, but in the write-up it says that CardioMEMS arm achieved an increased life expectancy of 0.44 years. So can you say more about it? I just don't know how to put that together.
So I'm going to have to leave that question for Dr. Sandhu when he talks about the economic modeling and the assumptions that went along with that.
I have a question about the level of evidence required for the promising but inconclusive rating. It's a single study, as I understand it, with industry-sponsored with 550 patients and mean age of, I just pulled it open, mean age of 61 in the treatment group and 62 in the control group, where we know that heart failure is a disease of the elderly. I'm wondering how representative this study is of patients with heart failure. I'm concerned about clinical effectiveness in real-world settings of this device.
Yeah. Again, the rating matrix that we use is intended as a guide for your own individual judgment. We concluded that there was moderate certainty not only because of the existence of one trial, but because of the potential for bias and confounding from the nurse communications issue. But again, that was ICER's conclusion. You can feel free to draw your own and think about some of the concerns you raised and others that you might hear about during public comment or what have you.
Could you comment just a little further about the sites that were included in the trial? Is there a sense that they were like all academic with heart failure clinics and programs already ongoing, or were there a lot of community single physician with a nurse settings? Do you have a sense of that?
There were a variety of settings. I think, again, I can get back and try to understand some of the more detailed aspects of these settings, but primarily these were academic centers with kind of specialty clinics that focused on heart failure, but not completely.
Domestic and international.
Domestic and international, not just U.S.-based. And one of the things that we tried to look for was whether there was some consistent description of what usual care meant or what the control group therapy meant in this case. And we couldn't really find a lot of detail, as I mentioned before, on whether patients got some other kind of detailed program or disease management approach to heart failure management at these centers. Should we move on to Entresto? Yes, Dan.
Just one more question.
Sure.
This confounding problem of the nurses, whatever benefit to the patients who had the device and had the data available would have influenced the nurses. But that is an intrinsic benefit of the device. So however the nurses acted, they could act in that arm of the study because they had that additional information. So whatever the effect is still traced back to the fact that there was pressure monitoring in those patients.
Right.
Thank you.
So, and in fact, in terms of the there's a lot of detailed information in the FDA documents around the characterization of those communications. And for the most part, the communications were rather mundane. This is the change in your patient's pressure. And there were scripts for both the treatment and the control groups that the study nurses were supposed to follow. In some cases, however, there were more detailed recommendations around potential modifications to treatment.
Which depended on the knowledge that accrued from
The
the
device.
device.
Right.
Thank you.
But to clarify, Dan, my point is that there is a lot of literature suggesting that just having nurses do follow-up for heart failure patients leads to improvement in outcomes even without monitoring, because, you know, there are lots of things we can monitor: weights, you know, symptoms, exams, and so that's why it has to really be clear in a trial that it would be the device and having those additional numbers as opposed to the other myriad ways we can do clinical assessment of heart failure from history, physical.
Right. Okay. So let's move on to Entresto then. And I'm only calling it Entresto because to say sacubitril valsartan would just take, I wouldn't even be able to finish before the sun went down. So again, there were multiple studies included in our evidence review. In fact, there's a phase 2 trial of Entresto, but that did not focus on the outcomes of primary interest for our evidence review. It's in the report, but for the purposes of today's discussion, I'm going to talk about the large phase 3 trial known as Paradigm HF. So this was a double-blind RCT of about 8,500 patients who received either Entresto or enalapril, an ACE inhibitor. The study was conducted in patients who had class 2, 3, or 4 CHF and an ejection fraction of 35% or less. Initially in the trial, the ejection fraction cutoff was 40%. There was a protocol amendment made and a reduction to 35%. The rationale for that was given kind of as a twofold reason. One was the 40% was felt to be too close of a cutoff to that might include patients with a more preserved ejection fraction function. The primary rationale was that with a lower ejection fraction, there would be more events, more deaths, and more hospitalizations, and a better chance for Entresto to show a benefit. In this case, the mean age was 64. About 3/4 of patients were male. The trial was stopped early at a median of 27 months of follow-up because of evidence of overwhelming benefit as identified by an independent monitoring committee in interim analysis. So in this case, the primary outcome, and in fact probably a major factor in the trial's larger size, was a composite of either cardiovascular death or first hospitalization for heart failure. In terms of absolute rates, about 22% of patients on Entresto versus about 27% of patients in the enalapril group reached this composite outcome. Translates into a hazard ratio of 0.8, a statistically significant difference. And you see numbers needed to treat in the table below. They're relatively similar for most of the outcomes taken together or independently. Numbers needed to treat between 20 and 35 or 36 for either hospitalization measures or mortality measures. The one outlier is emergency department visits with a number needed to treat of 83. But it's important to understand that this was emergency department visit for heart failure without a subsequent hospitalization. So patients were discharged home. That's relatively uncommon in this population. So in fact, I think a little over 2% of patients were treated in the ED alone in this trial versus 3.5 patients, Entresto patients versus 3.5 patients in the enalapril group. So a smaller absolute difference leads to a higher number needed to treat. In terms of worsening of CHF, so that's movement from one New York Heart Association class up to the next most severe, among those who survived at 12 months, this occurred in about 6% of Entresto patients versus a little over 7% of enalapril patients, a significant difference statistically. And here, quality of life and functioning was measured using the Kansas City Cardiomyopathy Questionnaire. Quality of life worsened in both groups over the period of follow-up, but worsened less, if I can say it that way, in the Entresto group in comparison to enalapril. In terms of serious rates of adverse events, or rates of serious adverse events, I should say, these were comparable between groups. Discontinuation of study drug due to an adverse event was somewhat lower with Entresto, about 11% versus a little over 12% for enalapril. Angioedema, which is defined as sudden swelling below the skin, is a concern with a lot of therapies for heart failure, including ACE inhibitors. This was nominally higher with Entresto, 0.5% versus 0.2% for enalapril, but was not statistically significant. In terms of subgroup analyses, in the main trial report, there were subgroup analyses conducted across a number of pre-specified subgroups, and the effectiveness of Entresto was similar across all of these groups: sex, age, race, medical and heart failure history, as well as level of ejection fraction. However, on the safety side, angioedema was more common in African American patients, I should say black patients because this was also an international trial, receiving Entresto, a little over 2% versus 0.5% in the enalapril group. In part to address this question on the post-marketing side, the FDA is asking the manufacturer to conduct a safety study specifically in patients, in black patients, to try to address this issue further. This study is going to be a real-world study using either claims data or electronic health record data. So there also were some uncertainties and controversies raised during deliberations, and in this particular case, this was approved using the FDA's breakthrough designation. There was no advisory committee, so the FDA conducted their own review and made their own decision. So there's documentation around that decision from the FDA itself. Also, other commentaries and editorials were things that we looked at. There was concern about whether, because this was a combination product that included an ARB that's already on the market, why the comparison was not between the combination product and valsartan alone. Because of that, it's not easy to understand what the relative contributions of sacubitril versus valsartan actually are. The rationale was that guidelines suggest that ACE inhibitor treatment, because ACE inhibitors have been shown to reduce mortality in patients with heart failure, ARBs have not, that ACE inhibitors should be the standard of care to consider for this particular population. And so that was really the major suggestion around that. The FDA is requiring a post-marketing comparative study comparing the combination product to valsartan alone, but that's really to address primarily a safety issue, which I'll talk about in a minute. Paradigm HF was also limited to patients who tolerated a so-called run-in phase, so they had to actually tolerate a short course of enalapril followed by a course of Entresto before they could be enrolled in the trial. And so about 11% of patients discontinued due to an adverse event with either or both of these drugs. And so the concern there is that this might be a healthier population that might otherwise be encountered in actual practice. And then finally, there is a theoretical correlation with the chronic inhibition of neprilysin and the potential for cognitive impairment or new onset dementia. And as I mentioned, the FDA is requiring this post-marketing RCT to try to understand whether neprilysin inhibition in the combination product is actually doing this. No differences in cognitive impairment observed in the trial. It's not listed here, but others had mentioned that this appeared to be a comparison of an optimized dose of the combination product to a moderate dose of ACE inhibitor therapy, because the dose of enalapril used in the study was 10 milligrams twice a day, and enalapril can be dosed up to 40 milligrams daily. But others commented that in practice it's very difficult to get patients up to that levels, and in the seminal trials that showed the benefits of ACE inhibitors, enalapril dosing was about 20 milligrams or maybe even a little bit less per day. Okay, so to summarize here, we felt that there was moderate certainty, and moderate certainty here again came from the fact that there was one phase 3 trial, but in this case of a small to substantial net benefit versus enalapril. Benefits for both hospitalization and mortality demonstrated in the study as a composite endpoint and individually. So our evidence rating, according to this level of certainty, is incremental or better. And we did not note any other particular benefits or disadvantages of this drug therapy, particularly. So I'll take questions on this, but why don't I just first summarize some of the public comments we received on our initial draft. Again, it was reaffirmed that the CHAMPION trial was not powered to detect mortality differences, and the trial should not be penalized for this. Again, we clarified our description, but our description now describes how the trial was powered, but that in terms of published data, there is no published evidence of a mortality difference with CardioMEMS. And it was also mentioned to us repeatedly that the FDA also acknowledged the limitations of the additional analyses conducted by the manufacturer, but nonetheless concluded that there was evidence of a positive treatment effect. They also felt that the magnitude of that effect was currently unknown. For Entresto, with specifically on the evidence review, we received no public comments. So questions? Dan.
Again, realizing that the panel is not bound by your judgments about the quality of the evidence, when a trial like this has statistically significant outcomes, in what sense would the rating be small? I mean, what were you looking for? What would give you substantial versus small?
Well, I think that so the statistical significance is obviously important, but it's also important to consider the absolute difference and one's own judgment of whether that absolute difference is replicable in other populations or in real world data.
Thank you.
Rita.
A few questions. One, just to clarify, I thought that there was actually a 20% loss in the run-in period, that it went from 10,000 to 8,000 patients.
There was a 20% loss, but some of those were protocol violations or patients dropping out for other reasons. So about half of the 20%, a little more than half of the 20% were due to intolerability issues.
And my understanding is also the run-in period was longer for Entresto than it was for the enalapril.
The audience is nodding yes, so I'm going to agree with them. Yeah, I think it was
I
maybe
mean,
1 week versus 2 weeks, if I'm right.
You know, obviously, when I
2
see
weeks, 4 weeks. Yeah.
when I see patients in clinical practice, I don't get a run-in. I give it to everyone. So
Understand.
you know, it makes it harder to extrapolate from results particularly with run-ins at all.
Sure.
Could you also comment on that quality of life? It was like 2.9 versus 4. What does that mean clinically?
Again, it's a modest difference. Here, it's not as if there was improvement in one group and worsening in the other. Quality of life decreased in both groups. And well, I'm not sure if the KCCQ has documented a minimum clinically important difference. It was a difference of about 1.5 points.
Like, what does 1.5 points mean? Do you feel better if you're 1.5 points higher?
Paul, maybe you can
They've, I mean, Well, in general, probably 1.5 would not be noticed by a patient. Probably need to get up to 4 or 5, but I would say on the population level, that 1.5 average could mean some 10-point differences in a fair number of people and 0 difference in others. So
Sure.
I'm very cautious in trying to apply that 1.5 to then every patient I see.
Right. What we typically look for is not only a presentation of mean differences, but also the proportion of patients who have achieved some sort of minimum clinically important difference, and that for neither of these studies, unfortunately, was that reported.
2 more questions.
Okay.
You mentioned it was approved on a breakthrough. What can you elaborate on what that actually would mean in terms of?
Yeah, well, we're just learning this ourselves because the FDA documentation hasn't been all that great on it, but essentially, when preliminary clinical evidence suggests that there's the possibility of strong clinical benefit with an intervention, the manufacturer can apply to receive breakthrough designation from the FDA. What that essentially means is a lot more early dialogue on trial design, as well as a rolling submission process. So the manufacturer does not have to provide all components of their NDA at the same time. They can do it on a more of a piecemeal basis. And while it's not guaranteed, the review timeline is usually shorter than it is for a standard submission.
And my last question, I'm interested that neither of these trials use mortality as a primary endpoint when, congestive heart failure, the reason we're all concerned about it is because it's a very, high mortality associated, and one would hope that we would power on mortality for these trials, but
Right.
neither did.
Yeah, this was powered on the composite. Mortality alone in this case was a pre-specified secondary endpoint and is reported on, as I showed you. But no, not powered on mortality alone. Anything else? Great. So why don't I turn it over to Dr. Sandhu now, who will talk about the care value analysis.
Good morning, everybody. As Dr. Ollendorf said, I'm going to be speaking about the care value and the kind of economic evaluation of both of these treatments. So I have no conflicts, and I wanted to thank the rest of the ICER team, along with Dr. Chapman, Dr. Ollendorf, and Dr. Heidenreich for helping with this analysis. So I'm looking at the outcomes, the costs, and the cost effectiveness for both CardioMEMS compared to usual care therapy and for Entresto compared to ACE inhibitor therapy. For both of these economic evaluations, we modeled the population that was used in the trial. For CardioMEMS, we modeled men and women with NYHA class 3 heart failure with an average age of 62. Both patients with reduced ejection fraction and preserved ejection fraction. Of that, about 80% was reduced ejection fraction and 20% was preserved. And all patients had a heart failure hospitalization within the last 12 months. And to take 1 second to clarify a question that was asked earlier about the baseline medication usage in this population. About 70+% were on ACE inhibitors, which is pretty good considering 20% were preserved EF, and over 90% were on beta blocker therapy, with about 1/3 having ICD or CRT. And for Entresto, we modeled the population of the Paradigm trial, which was men and women with NYHA class 2 through 4 heart failure, with an average age of 60. And this was only patients with reduced ejection fraction. We excluded patients with NYHA class 1 disease because the treatment was not FDA approved for those, although they ended up forming 5% of the Paradigm population. We used the payer perspective, including all healthcare costs, both for heart failure and non-heart failure, including the cost of the drug treatment and the device, and we used a lifetime horizon in our analysis. So now I'm going to show you kind of a quick model schema. Initially, patients will either undergo CardioMEMS intervention placement, or they will have usual care. The usual care arm means changing medications, titrating treatment based on typical signs and symptoms. For patients that undergo CardioMEMS placement, they can either have a successful placement or have a complication with either placement success or failure. After this initial period, patients enter a monthly model. During this monthly model, they're at risk for a heart failure hospitalization, a device complication if they have the CardioMEMS device, and mortality on a monthly basis. Individuals with the CardioMEMS device are assumed to have a lower risk of heart failure hospitalization monthly and assumed to have a higher quality of life. We assumed that heart failure hospitalizations carried a mortality risk during the hospitalization and carried a 2-month increase in relative risk of mortality after that hospitalization, based on literature estimates. And now kind of flipping over to the Entresto model. In this model, individuals could either be on Entresto therapy or ACE inhibitor therapy. They had a monthly risk of heart failure hospitalizations, ED visits for heart failure that did not require subsequent hospitalization, therapy intolerance, and mortality. Individuals with therapy intolerance on Entresto were then switched over to ACE inhibitor therapy, and individuals with intolerance on ACE inhibitors were switched over to angiotensin receptor blocker therapy. We modeled that individuals with Entresto have a lower risk of heart failure hospitalization, a lower risk of ED visits, a lower risk of cardiovascular mortality, with a similar risk of non-cardiovascular mortality, and an improved quality of life. All of those are based on the results of the respective trials for each treatment. The rates of therapy intolerance are independent to each treatment, again based on the trial results. So now we're going to take a look at the results, starting with the CardioMEMS results. In the CardioMEMS base case, we found that the usual care had 3.18 hospitalizations over the course of a patient's lifetime. That's per patient. The average life expectancy was 5.28 years. In the CardioMEMS arm, there was an approximate decrease in hospitalizations by 1 and an increase by about 0.44 life years in survival. This equated to an increase of 0.3 quality-adjusted life years and was associated with approximately $18,000 in increased costs, which led to a cost effectiveness of $57,933. So this is the base case results using our estimate of the kind of best input parameter values. We do conduct sensitivity analyses where we adjust the values of all of the probabilities, the costs, and all of the other inputs into the model. And we display these results as sensitivity analyses. So this is a graph of sensitivity analyses for the CardioMEMS model showing the 9 variables that changing the variable value most affected the cost effectiveness estimate. On the y-axis, you can see these are the names of the different variables that we changed. On the x-axis of this graph is the cost effectiveness estimate. Typically, we say that less than 100,000 per quality is reasonably cost effective as an American threshold, and greater than 150,000 per quality is typically not considered cost effective in the American healthcare system. To the left and the right of each bar, we have the input parameter values that we tested. For probabilities and utilities, those are the 95% confidence intervals of those values. For costs, we typically use 50% to 200% of the base case, with the exception being the cost of heart failure hospitalizations, where we use the average cost of low-cost hospital settings and high-cost hospital settings. As you can see, the variable that adjusting the value most affects the cost effectiveness ratio is the duration of benefit. In the base case, we assume that the CardioMEMS device would reduce cardiovascular hospitalizations and improve quality of life for the lifespan of a patient. If instead we assume that the device was no longer effective at reducing heart failure hospitalizations and didn't improve quality of life after the mean duration of the trial, 17 months, that cost effectiveness would increase to about $209,000. The cost effectiveness decreases below $150,000 per quality once the duration of benefit is greater than 28 months. and decreases below 100,000 per QALY if that duration of benefit is greater than about 55 months. What you can see is that adjustment of none of the other variables in this model lead to the cost effectiveness increasing above that 150,000 threshold. One of the other variables that doesn't actually make this model but was found to be highly uncertain was the cost of chronic monitoring of the CardioMEMS device. In the base case, we assume that the cost of monitoring was $27 per patient per month, based on the reimbursement for AICD monitoring. That cost would have to increase up to about $209 for the cost effectiveness to exceed 100,000 per QALY, and would have to exceed $427 for that cost effectiveness to exceed 150,000 per QALY. Those are the results for CardioMEMS. I don't know if I should go on to Entresto or take questions now. Okay, so I'm going to move on to the results for the Entresto analysis. So Entresto overall consisted of a population with lower morbidity. About 3/4 of these patients were NYHA class 2, and these patients didn't necessarily have a previous heart failure hospitalization. So the heart failure hospitalization rate in this population was lower, with the ACE inhibitors having 0.97 hospitalizations per patient over their lifetime. That compares to 0.9 hospitalizations in the Entresto arm. The survival in the ACE inhibitor arm is 6.78 life years, which with the Entresto arm having an increased 0.63 years compared to ACEs. This translated to about 0.57 quality-adjusted life years. The Entresto arm also had an incremental $29,000 in cost, approximately, which led to a cost effectiveness of $50,915. So again, this is the base case analysis, and we again conducted one-way sensitivity analyses of all of the variables in the model. And here I'm displaying the results of the sensitivity analyses for the 10 variables that most affected the cost effectiveness. Again, you can see that the variable that the model and the cost effectiveness estimates is most sensitive to is the duration of benefit, which is that top variable. Again, in this analysis, we assumed that Entresto reduced cardiovascular hospitalizations, reduced cardiovascular mortality over a patient's lifetime. If instead we had assumed that that duration, that benefit ceases after the mean duration of the trial, which is about 26 months, that cost effectiveness ratio increases to 136,000 per QALY. The cost effectiveness ratio goes below 100,000 per QALY if the benefit of the treatment exists for at least 39 months. And what you can see is that variations in none of the other variables in this model lead to a cost effectiveness greater than 100,000 per QALY. The key limitations to this model are that the input parameters and the data of effectiveness are defined from a single clinical trial that was industry-sponsored for each treatment. The clinical effectiveness may vary when it comes to real-world results. And we don't have great data about the long-term effectiveness after the trial duration, which we can see as an important parameter in determining the value of these treatments. There's also a high amount of uncertainty regarding the costs of long-term CardioMEMS monitoring. However, we've shown that those costs would need to be quite high to materially affect our results. In conclusion, the cost effectiveness for CardioMEMS is about 58,000 per QALY and is fairly robust to most sensitivity analyses. That being said, the cost effectiveness would go above 100,000 if the benefits of the device cease after 55 months. In conclusion for Entresto, the cost effectiveness is about 51,000 per QALY, and again is quite robust to sensitivity analyses, but the cost effectiveness would go above 100,000 if the benefits of the device cease after 39 months. Are there any questions?
Son, yes. A question about the sensitivity analysis. Obviously, the duration of benefit is the key mover of this, and your projection was that these benefits might accrue to the patient over the life of the patient. One question is, in this subgroup of patients with heart failure, what was your estimate of their lifespan? And secondly, how did you look at the probability that the device or the drug would work beyond the length of the trial? I mean, I realize that's implied in the sensitivity analysis, but did it influence your final value judgment where you made a guess as to the duration of benefit?
Yes, so both of these are heterogeneous groups of population. For CardioMEMS, it's a combination of 80% patients with reduced ejection fraction and 20% with preserved. And we found that the average survival in our model was 5.28 years for a usual care arm. And for Entresto, I believe, was just over about 6.7 years. With regards to the question about how we extrapolated the effectiveness after the trial duration, in the base case, we assumed that the effectiveness seen during the trial was maintained during the entire patient's lifetime. And then in the sensitivity analyses, where we varied the duration of benefit, we then assumed that the treatment has zero effectiveness after that cutoff point.
Just to clarify, I'm sorry again. If I understood you correctly, you said that those life years were based not on the mortality that was seen in the actual trial, but on some other projected mortality? And why would you have not used the mortality from the trial?
We didn't use the mortality data that was in the trial for CardioMEMS because it was not statistically significant and not powered for mortality reduction. The documents submitted to the FDA showed a hazard ratio of 0.8, so about a 20% relative reduction in mortality as a point estimate, with the confidence intervals, I believe, from 0.55 to 1.15. So we didn't want to extrapolate that would be the kind of definite mortality estimate because it wasn't really powered for that endpoint. So what we instead did was a compromise, assuming that the natural history of hospitalizations are associated with mortality, using literature estimates for that association. So in our model, what we ended up finding was that the relative risk for mortality with the CardioMEMS model was about 10% reduction.
I guess that gives me less confidence in these data, just because it doesn't seem to have the actual data to be able to model it. But I wonder if it does address the question you raised earlier of why it was 0.44, although that looks like 0.3 to me. But
So this is where the 0.44 comes from. And we in sensitivity analyses, did vary the estimates of mortality substantially. If we use the trial's estimates of mortality to drive the trial, the cost effectiveness becomes about $44,000 per QALY, and that's in the full report. If instead we had assumed that hospitalizations have zero association with mortality, that patients with the CardioMEMS arm will have fewer hospitalizations but live the exact same life expectancy, that cost effectiveness goes to about $110,000. And then if we assume that there was no relative risk change after the hospitalization, but that inpatient hospitalizations have a 50% reduction in mortality, that goes to about $85,000 per QALY.
But it seems like based on the trial, we just don't know if there is a mortality benefit or not.
I think I would agree with that. I think it's uncertain whether there's a mortality benefit, and I think understanding the association between the reduction in hospitalizations and associated mortality will be an important question going forward.
It's not really to you, but for both of these cases, they were approved on the basis of one randomized controlled trial, and for drugs, we usually see at least two devices sometimes, and I'm wondering if you could comment on the confidence in why there was only one RCT.
I'm not sure I can comment on the decision for there to be one RCT for each of these treatments. I can say that, you know, one of the values of the economic modeling is we can look at the different factors that determine the value. And if you look, for example, at the heart failure hospitalization relative risk with CardioMEMS, we can see that even at the kind of upper limit for their hospitalization reduction, the cost effectiveness remains below 100,000. But I'm not sure I can comment on the overall decision with regards to the number of trials.
I think we need to move along. Dan, are you ready?
I am. So I'm going to get to budgetary impact now. But before I do, I told you we have a crack team back in Boston at ICER, and they've sent me some additional information that I should probably share with you. The run-in period in Paradigm HF was 15 days on enalapril, followed by 1 month on Entresto. Entresto was not approved as a breakthrough drug, but rather as a fast-track / priority review drug. Fast Track is an older program. Breakthrough designation has replaced a lot of those components, but it still involves frequent meetings with FDA staff and this ability to do rolling submission. Priority review essentially is a way to reduce the FDA's review time from typically about 10 months to 6 months. So that's Paradigm HF. The Champion trial was done at U.S. sites only, not an international study. All we have to go on in terms of the mix of sites is a list of investigators, and it looks like it's about 2/3 hospital-based cardiology practices, about 1/3 community-based cardiology practices. The post-marketing studies, I think, Rita, you had mentioned this, are going to be open-label trials, but they're compared to historical controlled data, not to a controlled group. So that's that. Okay. So let's move into budgetary impact. I still have no conflicts of interest. I do want to acknowledge the work of ICER's Director of Health Economics, Rick Chapman, in helping develop this section. So there are sort of lots of detailed technical descriptions in the full report itself, which you all have read. But to kind of briefly summarize the methods for the budgetary impact analysis. So essentially, what we're charged with doing here is we're taking output from Dr. Sandhu's model on the cost associated with both the device for CardioMEMS and the drug for Entresto, as well as any cost offsets associated with reductions in heart failure, hospitalization, or death, and applying them to an estimate of the population size for the target populations for these two interventions. And we used published data to try to estimate the prevalence of Class 3 CHF in patients who would have been hospitalized within the prior 12 months. And we arrived at a number that's about a little less than 300,000 per year, 287,000 to be precise. We, for each of these, had to assume some level of uptake. So as is documented in the report, what ICER tries to do is to examine uptake in a quote-unquote unmanaged way. So we're not trying to guess what kind of controls payers might put in place or what other market forces or dynamics might be at play. We're trying to understand, based on the level of unmet need and the other options patients have within any given target population, how many patients might receive the intervention by 5 years. Our budget impact timeline is 5 years long. So for Entresto, for CardioMEMS, we assumed a relatively modest uptake by year 5, so 25% of the 287,000 patients annually would have received the device by year 5. That equates to an estimate of 359,000 patients receiving the device by 5 years. For Entresto, this is a broader population, and so the number of patients estimated to have class 2 to 4 disease and reduced ejection fraction is about 2.2 million. We assumed here that given the benefit that's demonstrated in the Paradigm trial over an existing therapy that has already been shown to have benefits of its own, that uptake would be brisker here. So 75% of patients in this target population would have received Entresto by year 5. And that equates to a total of 1.7 million patients. Now, it's important to understand some nuance between drug and device here. So Entresto is a chronic therapy, and without any published models of what the uptake curve might look like or the statistical function associated with it, we assume that uptake would be linear. So that means that 20% of this population would receive the drug in year 1, 20% in year 2, year 3, 4, 5, et cetera. So for a chronic drug therapy, what that essentially means is that budget impact is calculated based on a mean of 3 years of therapy, right? So 20% get it in year 1 and so on through year 5. So the average length of therapy across that 5-year timeline is 3 years. CardioMEMS, of course, does have ongoing monitoring costs, as Dr. Sandhu mentioned, but the primary cost associated with it is the cost of implantation, and that happens as a single event. So there, most of the costs are borne in each year of the 5-year time horizon, as opposed to some sort of average for chronic therapy. So important to understand that. So the other reason why we are trying to look at uptake on an unmanaged basis is that we want to try to compare it to some budget impact threshold for decision making. And that threshold really represents a dollar amount above which decision makers should think about whether they need to manage the additional cost of a new intervention. If it's below the threshold, maybe no significant management efforts are required. If it's above the threshold, maybe some other conversations have to be had. And so we've developed methodology which is publicly available as a presentation right now. We're working on a publication for the peer-reviewed literature as well. Lots of details on the calculations in the report, but just briefly, this is based on a target for overall healthcare cost growth, which we've set at GDP plus 1%. It also is calculated based on the number of new drug or device approvals annually to try to understand what share of that growth should be apportioned to each new intervention, and the contribution of either drug or device spending to overall healthcare spending. It's about 13% in terms of latest estimates for drugs. It's about 6% for devices. And again, this really serves as not a cap, not a sort of a black and white binary threshold, but as a policy trigger for discussion. So for 2015-2016, the thresholds we've calculated are $904 million annually for drugs and $603 million annually for devices, respectively. So now to turn to our actual budget impact results. So you see, again, the size of the treated population, which is based both on prevalence and our assumed level of uptake of each of CardioMEMS and Entresto, respectively. Over that 5-year time horizon, the annualized budget impact is about $1 billion for CardioMEMS and about $3 billion for Entresto. And in order to, taking into account both the price of the device and the drug, as well as the cost offsets that would be realized through the use of the device and the drug from the model outputs, the discount on that price that would be required to match the thresholds I just produced of $904 million annually and $603 million annually for devices would be about 40% for CardioMEMS and a little under 9% for Entresto. So I'll take questions in a minute, but just to turn to public comments received, not surprisingly, we got the most comments about this part of the analysis. So initially, we had received some information from the manufacturer about the candidate population size, and we had based this really on hospitalization frequency as opposed to the number of unique patients who would be hospitalized. Of course, in any given year, patients can be hospitalized more than once. So we had to adjust this to reflect the number of unique patients who would be hospitalized. We also got comments suggesting that we've significantly overestimated uptake in some cases. Other comments said we've significantly underestimated it. So I guess you can take what we've estimated as you will. In terms of Entresto, in the absence of a lot of clear trial-based data, we had assumed a proportion of patients who would be Class 1, who'd have Class 1 disease and thereby be excluded from our budget impact analysis. That was based on Paradigm HF, and that was too low a percentage because, in fact, the only Class 1 patients in Paradigm HF were patients who had improved heart failure from Class 2 down to Class 1 because they were not actually they were not entered into the trial. So we went to observational data instead, and we picked an example that's reflective of a broad set of treated populations to estimate the proportion who would be Class 1 and be excluded, and that's actually closer to 25%. In addition, our original estimate for CHF prevalence, 5.7 million, has been repeated in multiple publications, but is a bit outdated because it's based on 2009 to 2012 NHANES data. So we updated that prevalence estimate based on a projection for 2015 to 6.2 million. So now I'll take questions. No questions on budget impact? Oh, one, okay.
Yeah, I just wanted to just underscore that I think we don't have a clear picture of what the cost to an organization such as a big provider organization or a health plan for any infrastructure to manage these patients on the CardioMEMS would look like. And that's one of the things I hope we learn through the day, because if we don't know what that looks like, we don't know what those costs look like.
Right, so our focus has been on essentially healthcare system costs, costs that would be reimbursed by payers as opposed to investment costs that are required by practices and institutions. Any other questions? Okay, on to public comment.
Okay, public comments. We have 9 speakers who have requested time. I would invite them, and I will announce each one in order, to come up to the microphone to announce their conflicts of interest, which in many cases are obvious from their titles. Our first speaker, and their remarks will be held to 3 minutes, and I believe Karen will have the signs. Our first speaker is Dr. Robert Hilkert, who is Vice President, Head, Cardiovascular and Respiratory Medical Unit, Novartis Pharmaceuticals. Dr. Hilkert.
So, excuse me. Good morning, Dr. Urliet and members of the panel. My name is Bob Hilkert. I'm a board-certified cardiologist and Vice President of Cardiovascular Medical Affairs at Novartis Pharmaceutical Corporation. We very much appreciate the opportunity to present our perspective on the current impact of heart failure on both the U.S. healthcare system and also to share our passion for the significant value that Entresto will provide to patients with heart failure with reduced ejection fraction, their families, and the healthcare system as a whole. We also want to thank ICER and CTAF for considering our comments and for updating the report on the health system value of Entresto. Heart failure is a devastating public health concern with increasing impact. As you've heard today, over 6 million patients are afflicted with heart failure and its profound consequences. In fact, 10 patients will be diagnosed with this condition before my short talk is over, and 1 patient will die every 10 minutes while we are sitting here in this meeting. What's more, the healthcare costs to the U.S. healthcare system are staggering at over $30 billion presently, and they're expected to rise to almost $70 billion by the year 2030, which indicates the dramatic need for investigation of new therapies. Entresto represents a clinically and cost-effective option for reducing the burden of heart failure for REF patients and has been shown to keep people alive and out of the hospital. The efficacy and safety of Entresto was demonstrated in the Paradigm HF trial, as you heard, which was the largest heart failure trial done to date in this population and provides a significant contribution to our understanding and management of the disease. This trial is a direct head-to-head comparison of Entresto to the ACE inhibitor enalapril, which has been seen as the gold standard for treating these patients for the past 2 decades. As you heard, the trial was stopped early by the Data Safety Monitoring Committee due to the overwhelming efficacy of Entresto. The Paradigm trial demonstrated the superiority of Entresto in reducing the risk of the primary endpoint of cardiovascular death or hospitalization by 20% with a highly significant p-value. And I do want to specify one of the comments made earlier. The trial was powered for cardiovascular mortality and in essence was overpowered for the primary endpoint. So when we moved that, we did increase the sample size because we wanted to show the effect on mortality. In addition, all-cause mortality was reduced by 16%, which was highly significant. Other significant endpoints included a reduction in all-cause hospitalizations, a reduction in total heart failure hospitalizations, reduction in emergency room visits, reduction in the risk of sudden cardiac death or death due to worsening of heart failure, and positive benefits on quality of life. These findings were consistent across all subgroups that were examined. And importantly, Entresto patients experienced fewer serious adverse events and fewer discontinuations of study drug during the trial. Based upon this, as you heard, the FDA granted us approval early in July of this year through a priority review and a fast track designation. We acknowledge the value of an independent and transparent clinical and cost effectiveness evaluations of new therapies. We're pleased that Entresto found, we're pleased that ICER found Entresto to be clinically effective and highly cost effective, as well as well below the ICER threshold, which reflects Novartis' responsible pricing for this life-saving therapy. We're committed to providing the heart failure patients, healthcare providers, and payers with the benefits and provide the best access for those patients. So in summary, Entresto represents a paradigm shift for patients with reduced ejection fraction heart failure and offers significant clinical benefits, care value, and health system value. Thank you for this opportunity.
Thank you, Dr. Hilkert. Just a word to the panel. Because of the number of speakers and the time constraints, I'm going to limit the questions unless there is a burning question that must be asked. I think we'll just go in order. And our second speaker is Dr. Mark Carlson. Dr. Carlson is Vice President, Global Clinical Affairs and Chief Medical Officer, St. Jude Medical.
Thank you. Good morning, and thank you for allowing me the opportunity to address ICER's analysis of CardioMEMS evidence and the economic assessments offered by the Institute. As was said, my name's Mark Carlson. I'm a cardiologist, and I'm the Chief Medical Officer of St. Jude Medical. As the manufacturers of the CardioMEMS heart failure system, we provided written comments to ICER on the original draft report and appreciate some of the changes that were made and are reflected in the latest draft. Unfortunately, the most current draft offered by ICER does not accurately reflect clinically meaningful and statistically significant comparative outcomes that favor the use of CardioMEMS system for Class 3 heart failure patients. While we appreciate that the more recent draft concluded Level 1 evidence and experience was promising but inconclusive, we contend that the appropriate designation for the system is B+, based on the robust clinical evidence that demonstrates the statistically significant and clinically relevant reduction in heart failure hospitalizations for appropriately indicated patients. Such a rating is more reflective of the significant and proven benefits of the technology while recognizing that a newer technology, more clinical trial and real-world evidence can confirm the clinical results shown to date. We offer the following comments in support of our B+ recommendation based on key points in various sections of the revised report. We call to CTAF's attention gaps in the ICER assessments that require further review. First, the revised report calls into question the additional analyses that were conducted by the sponsor subsequent to the FDA panel, as they were not conducted a priori. The revised report does not accurately represent the analyses, which included 1, an audit by 2 independent heart failure specialists, 2, a propensity-matched analysis regarding nurse communications, and 3, additional data collection for a mean of 13 months in which the physicians had access to the PA pressure data for all patients to guide medical decision-making, and where no communications occurred between the sponsor and investigator. So at that time, all of the patients, even the control group, were treated with the pressure-guided information. All of these analyses were agreed to by the FDA prior to the data being collected and/or the analyses being performed. The report incorrectly downplays the audit by the 2 independent heart failure specialists. We take issue that the revised report includes what appears to be the opinion of the report's authors while dismissing the findings of 2 independent cardiologists. Third, while the propensity score analysis was mentioned in the revised report, the report fails to include important information relative to the findings of the analysis. Per the PMA submission to the FDA, the results demonstrated a consistent reduction in the rate of HFR hospitalizations, heart failure rehospitalizations, in the TNNC as compared to the rate in the propensity matched controls using Part 1 study data. The results are consistent with original study results and longitudinal analyses. There is much more that I could say, but I have a red flag in front of me. And I would love to answer questions and correct some of the misinformation that we heard earlier.
Thank you, sir. All right, our next speaker is Dr. J. Thomas Haywood. Dr. Haywood is Director, Heart Failure Recovery and Research Program at Scripps Clinic. Dr. Haywood.
Thank you very much for the opportunity to speak with you today and hear these presentations. My conflicts are I speak and I do research for most of the device manufacturers, and I've been involved in all the clinical trials in hemodynamic monitoring over the last 15 years. That's what I really want to address today. I think I want to take CardioMEMS out of the vacuum and look at the greater context from which this device developed. The first device was a right ventricular pressure monitor made by Medtronic called the Chronicle device in the COMPASS trial. Although its primary endpoint, it was underpowered study as it turns out, but it did look at a secondary endpoint of hospitalizations, and there was a 30% hospitalization reduction with that device, very similar to what we saw with CardioMEMS. So I think that's added data. We also had the left atrial pressure monitor with the homeostasis trial, although not a similar trial like this, but we also demonstrated that we could lower pressures by monitoring patients chronically. So I think we have other data that shows that this technique works and that we can lower hospitalizations in patients. Some of the other comments have already been made. I wanted to underscore the effect on patients with normal ejection fraction. This is a huge problem in the United States. Fully half the hospitalizations for heart failure have a normal ejection fraction. And as the panel knows, there's no effective therapy for them. ACE inhibitors don't work, beta blockers don't work, spironolactone doesn't work, CRT doesn't work. Really, no neurohormonal modulating therapy works. However, hemodynamic monitoring with the CardioMEMS system reduced hospitalizations even more than low EF patients, a full 50%. And as we don't have anything to offer these patients, and because they're so common, I think this really has to be underscored as an important breakthrough in our ability to manage patients. Fully, more than half of the 20 patients that I fully monitor have this. I also wanted to say about the numbers. I come from San Diego. I think we're a fairly active heart failure. There's 12 heart failure specialists in San Diego. We have 3 LVAD programs, 2 heart transplant programs. There's about 3 million people in the metropolitan area of San Diego. About 40 CardioMEMS have been implanted this year. And my rate of implantation has actually gone down because I've done the patients that I think I've needed to do. There's many patients that are demented, that have renal failure with heart failure, that are not appropriate for this technology. So I think the numbers are going to be much smaller than what's estimated for this. Finally, I think we lack the patient perspective for this. I have patients that live way more than 100 miles from my clinic. It's very difficult for them to come to the clinic. I can monitor these patients and manage them in ways that I couldn't do it before. They don't have to come to the clinic, yet we can monitor them in a way I think they get better care than they used to get. And they're very thankful that they can live their lives and don't have to come to the doctor's office quite so much. So thank you very much.
Dr. Haywood, stay there for just a minute. There's an urgent, burning question.
Okay.
Yeah, thank you.
That
I
Dr.
just
Red,
wanted,
Yes.
I just wanted to clarify, talking about the normal ejection fraction, you said had none of the treatments work.
Yes.
But that these patients did better. But this is a monitoring device. So how did that translate into doing better?
Well, there are 50% reduction in hospitalizations for them, as opposed to 30% in the overall trial. PA pressures went down. We're able to diurese them. So it's hard to know how much medicine to give them on clinical exam. And so by knowing what their pressures are, we can lower their pulmonary artery pressures, and that's what drives them into the hospital when they decompensate. It's really a unique way to manage patients.
Thank you very much.
Yes, and nitrates and blood pressure control.
Thank you, Dr. Haywood.
Thank you very much.
Our next speaker is Dr. Scott Lowvold. Dr. Lowald is Senior Associate Biomedical Engineering at Exponent. Dr. Lowald.
Thank you very much for the chance to speak. As mentioned, my name is Scott Lowald with Exponent. I am speaking on behalf of Exponent colleagues who cannot be here today. Dr. Kevin Ong, a principal engineer in the biomedical engineering practice, and Jordana Schmier, a senior managing scientist in the health practice. Exponent was engaged by St. Jude Medical to review the ICER CardioMEMS report. And forgive my choppiness, we were timed to 5 minutes. I cut out a few things, so I'll skip through here. With limited time available, we will highlight 3 main concerns about the report and the model it describes. First, using a maximum budget impact threshold for affordability is problematic. It is inconsistent with the goal of equitable rationing of limited healthcare resources. It minimizes the importance of cost-effectiveness analysis and ignores both the burden of disease in the population and the innovative nature of treatment. Use of a threshold essentially penalizes patients with high prevalence conditions, as interventions must not only be cost-effective, but also cheap because there are so many eligible patients. Rather than providing equitable treatment across beneficiaries, the use of a threshold instead promises equal consideration across devices and does not account for the type and prevalence of the conditions the devices are intended to treat. Second, the adoption rates for CardioMEMS are overestimated. They fail to consider available sales data in estimating first-year utilization and projecting the adoption rate. Public sales figures for the first 3 quarters of 2015 are available. Best practices endorsed by ICER and the National Pharmaceutical Council, among others, recommend the use of actual sales data for budget impact assessments. Data from 2015 project $90 million in CardioMEMS sales. Using the average sales price of $17,750 in the report, this equates to 5,070 units. The report suggests a budget impact of $1.1 billion in the first year based on treating 72,000 patients. Scaled down to reflect only 5,070 patients, this would be less than $80 million for the year. CardioMEMS investor reports and published accounts of the adoption of implantable cardiac devices suggest a much slower rate. The analysis must be rerun using an evidence-based starting point and creating a new, more realistic uptake category. Finally, we identified flaws with the model structure and input parameters. The exclusion of mortality data from the CHAMPION trial based on not achieving statistical significance is not aligned with current thinking about cost-effectiveness analysis, which acknowledges practical limitations on sample size and encourages presenting confidence limits rather than disregarding data. Further, hospital cost estimates, while inflated, were based on studies that are more than 5 years old and should be replaced with newer findings. Finally, the model does not seem to take into account the progressive nature of heart failure, in which each hospitalization is associated with increasing decrements in quality of life and greater cost burden. These flaws individually and collectively minimize the effect of CardioMEMS. At the very least, sensitivity analyses considering these inputs should be conducted. Thank you for the opportunity to comment on the report and raise our concerns. We would be glad to share additional comments with ICER.
Thank you, Dr. Lowald. Since you've raised a number of points here, I would call on Dan to respond, and you will be under the clock. You're
How much time do I have?
3 minutes.
Okay.
Or 5 minutes, 5 minutes.
Okay. So I think there are things that both Alex and I can respond to. So again, as we've characterized our budget impact threshold, we have not discussed this as a cap. We discuss this really as a recognition of the notion that health systems have to contend with paying for new interventions, and in some cases paying for these interventions in large populations, and having to understand how to reallocate resources based on that. I think that in our discussions with the panel on our overall value framework, the considerations really need to be considered as a companion. So the cost effectiveness results, the care value results as we describe them, need to be taken into consideration, but the idea of health system budget impact is another consideration that needs to be considered as part of the whole. So we don't feel that our budget impact threshold ignores the cost effectiveness findings, but merely provides an additional point of information. As I mentioned, adoption rates or uptake estimates in our model are done on an unmanaged basis because we know that payers will vary in how they're going to estimate this or put controls in place. And, in fact, the understanding of utilization as it is reflected in this threshold might give a signal as to whether health systems need to manage the costs of a new intervention. So this threshold is really put in place as a trigger for discussion as opposed to any sort of arbitrary cap. And in addition, we have our own sensitivity analyses in the report that look at the budget impact as aligned to different rates of uptake across the spectrum. And then I think there were two questions on the cost-effectiveness analysis I'll let Alex address.
With regards to the analysis of mortality, again, we didn't assume the mortality reduction in the trial because it wasn't a primary endpoint and because the range of possible hazard ratios was from 0.55 to 1.15, so indicating a 95% confidence interval between a 45% reduction in mortality and a 15% increase in mortality. Therefore, we assumed our best estimate of the natural history of association of hospitalizations and mortality. That being said, we did analyze that in sensitivity analyses that are included in the report. And if we assume their point estimate for mortality reduction of 20%, that cost effectiveness dropped to about $48,000 per QALY. If, on the other hand, we assumed no mortality reduction or a hazard ratio of 1, that cost effectiveness increased to above $110,000 per QALY. So we did consider how those would affect the cost effectiveness going forward.
Thank you, gentlemen. Our next speaker is Brett Johnson. Mr. Johnson is Director, State and Local Government Policy, California Life Sciences Association.
Hello. Yes, and thank you for the opportunity to comment on the revised ICER report on the CardioMEMS heart failure system for congestive heart failure management. Just to sum it up front, we disagree with some of the methods and conclusions of ICER in the analysis and the determination that current evidence for the technology is promising but inconclusive, and we would recommend a revision to a recommendation of B+. We believe deficiencies exist related to both the analysis of clinical benefit and cost effectiveness, which we believe should be considered in your vote on the ICER report today. First, regarding clinical benefit, we believe some significant consideration of CMS's findings that CardioMEMS represents a substantial clinical improvement was in order. CMS's findings were such that it was approved both a new technology add-on payment in NTAP and the transitional APC pass-through payment status for outpatient discharges. Furthermore, the ICER report emphasized the CHAMPION trials analysis on mortality, despite the fact that the study's primary endpoint was reduction in heart failure hospitalization. But we believe we've talked about that at length here. We also assert that critical subgroup analyses of CHAMPION should have factored more prominently into the report. And then, for instance, there was also a CMS subgroup analysis of roughly 50% of the trial that showed a drastic reduction in 30-day readmission for heart failure. And I believe that it was about 78%, and that was statistically significant. Second, regarding cost effectiveness, in considering the aforementioned analysis, we believe ICER's cost effectiveness analysis may warrant some revisiting or at least noting of some additional factors. While we understand the rationale for an assumption of unmanaged, which we just talked about, while we understand that assumption, we're moving into an era of healthcare, especially in California, where less and less reimbursement has no performance or quality-based component. We're also seeing, an explosion in adoption of patient-centered medical homes, things like comprehensive medication therapy management, and just a number of new models that could really benefit from this type of intense monitoring, as we heard from some previous speakers. So I guess I'll sum it up now. But we further hope that ICER will consider St. Jude Medical's comprehensive cost-effective analysis, which calculated a comprehensive incremental cost-effectiveness ratio of a little over $30,000. A little over $30,000 over a 5-year time horizon. And wrapping it up, we hope that you'll consider these analysis and previous speakers.
Mr. Johnson, any conflicts of interest?
Oh, no conflicts of interest other than a representative trade association of many of these companies. Thank you.
Our next speaker is a registered nurse, Nancy Cannot. She is the heart failure nurse navigator at John Muir Medical Center.
Hello, good morning. Thank you for allowing me to speak today.
Good
morning. So I have no conflicts of interest. I'm here to talk about how CardioMEMS heart failure system has helped manage my heart failure patients in my Heart Failure Resource Center. So as he said, my name is Nancy Cannon. I'm the heart failure nurse navigator for John Muir Medical Center. We have about 350 to 400 hospitalizations for heart failure a year. I provide inpatient cardiac education. I'm responsible for the hospital quality measures and AHA get with the guidelines for heart failure and run our nurse-managed hospital-based heart failure clinic. I've been a nurse for over 30 years, and I've been a certified heart failure nurse for over 5 years. For the last several years, the majority of my time is spent managing these complex patients with multiple comorbidities. I've been involved with telemonitoring, home visits, care transitions. As the gentleman said before, there's many more new models out there for trying to manage these chronic conditions at home. We make the post 24-hour discharge calls and assure follow-up appointments within 7 days of discharge. I've come to find out there's not a single magic fix for every patient event hospitalizations and improve their quality of life. With our implementation of St. Jude CardioMEMS heart failure monitoring system, I've found it a very valuable tool in my toolbox. We started implanting CardioMEM in June of this year and to date have 11 patients implanted with the PA monitoring system. This is the first time in my career that we now have a real-time, accurate information to rely on as a barometer of our patient's fluid status. Whether it's fluids or, my patients just like their pasta, weights are not always accurate, of their fluid status. The PA pressures can give us accurate measurement of the patient's volume days and weeks ahead of there being any weight changes or symptoms, and we're not now having to chase their volume increases and impending hospitalizations, but keep the patients at a more euvolemic state, help protect their kidneys, and most importantly, keep them in their home and out of the hospital. On a daily basis, we can see any changes in pressure, and with the direction of our cardiologists, implement medication changes and order lab work. To date, we have not had any 30-day readmissions. I believe this type of innovative technology is imperative in managing these chronic conditions at home. It truly is a looking glass into the soul of our heart failure patients. Thank you.
Thank you very much. We have 3 more speakers. Our next speaker is Dr. Klein. Dr. Klein is Associate Professor of Medicine, UCSF, and Director, Mechanical Circulatory Support and Heart Failure Device Programs. Dr. Klein.
Thank you so much. As you said, I work at UCSF. My conflicts are that I've been an investigator in the Champion trial, and I'm also an investigator in the post-approval study for CardioMEMS. I want to bring my experience and comment on the impact on the care organization, how it has actually impacted our practice. We have over a couple dozen patients experience over time, and we're fortunate to be the first center to implant it commercially in the Western U.S. So we have about a year worth of experience in these patients. We recently did our own analysis to looking at hospitalization in these patients. So I can tell you the year before the CardioMEMS was implemented, we had about 1.6 hospitalization per patient. We had 0 hospitalizations since we implemented CardioMEMS. The number of ER visits for heart failure were 0.4 per patient. In the previous year, decreased to 0.2 per patient after implementation of CardioMEMS. The number of office visits, which was actually very interesting, we had about 6.5 visits per patient in the prior year, which decreased to 3.6 visits per patient. The number of telephone calls and the amount of time spent by the nurses on phone calls actually increased significantly, went from about 19 minutes per month to about 59 minutes per month. The phone calls, as you can imagine, are directing the patients to change therapies, to go get the labs, and then communicate those results. So I think, in summary, although we had an increase in the nursing communication to the patients, we're fortunate to not have any readmissions and decrease the number of emergency room visits. In addition, I want to echo Dr. Haywood's and Nancy's comments about patients' improvement in clinical status, especially heart failure with preserved ejection fraction patients. We actually had a couple of patients that we tested functional status, and their 6-minute walk distance improved significantly when their PA pressure was lower. In addition, anecdotally, we had a few patients that we probably saved from renal failure when they had, for instance, diarrhea, continued to take their diuretics. Had they not been alerted by us that their PA pressure had decreased, they probably end up in the emergency room with renal failure. So I think, in summary, in clinical experience, we did not have to increase our nursing staff to take care for these patients. We could take care of our existing environment, and then we had a significant reduction in clinical events with a minimum increase in actual phone calls for these patients.
Thank you very much. Our next speaker is a patient, Mr. Michael O'Connell from Sacramento will address us. Mr. O'Connell, thank you for being here.
Thank you very much for having me here. I'm not a doctor or medical professional here. I'm actually a comedian from Sacramento. So usually when I'm having a microphone in my hand, the audience is a lot more intoxicated, so this is quite a treat. So thanks for having me. I just wanted to speak as someone who recently, as of August 21st, I got the CardioMEMS implanted, and I just wanted to give you some information on what it's like to actually have this and the benefit. I am 47 years old. I have Emery-Dreifuss muscular dystrophy, and with that type of dystrophy, heart problems are inherent to that. I've been dealing with those since I was about 20, but it's gotten worse with the heart failure over the years. My ejection fraction is right about 15% right now, so there's a lot of monitoring and things that go on with me, and a lot of hospitalization. I've been in 7 times this year with that, and being in the hospital is not a pleasant experience for anybody, but especially so for me. There's a lot of reasons for me why it's really torturous being in there. So once I'm a patient at UC Davis Medical Center, and I believe I was number 10 of the CardioMEMS implants there. Got a wonderful cardiology team there, and they felt it would benefit me quite a bit. So that was put in, like I said, in August. It's made a very big difference for me personally. There was a discussion mentioned earlier about anxiety versus reassurance. Very reassuring to know that's there. Every day I'm being monitored, and because my situation is a little more urgent than some heart failure patients, they're monitoring me daily. My cardiologist even calls me or texts me on the weekends with my readings, and they adjust my diuretics accordingly, which is important because not only with the heart, but I have been through renal failure, ended up in the ER because I was over-diuresed. So every day they're monitoring that, and just that peace of mind of knowing that they're there, and that means less trips to the doctor, less trips to the hospital, is a wonderful thing. And I've been nothing but happy with it and the people involved so far. So I just want to give kind of a patient's perspective on that.
Mr. O'Connell, I have a burning question.
Yeah.
Can you inform us about the process by which you communicate your pulmonary artery pressures to your managing physicians? How do you get the numbers, and how do you communicate it? Can you talk about that process?
Certainly.
You say you do it daily.
Yes.
So tell us how that happens.
First thing I do every morning, there's a device that comes with it, the CardioMEMS. It's a kind of a, I don't know what you call it, a wand or a reader of some kind that's in a pillow. You just normally lay on the pillow and get your readings. Unfortunately for me, that wasn't working. Once I'm laying down, I can't really move myself. I have other people move me around to get to just the right spot to get a good reading. So what we've done is we got the manufacturer's approval to go ahead and take that out. So I get up and my father puts it on my back every morning and we move it around until it gets the right spot and the right reading. And then it sends it.
How big is the wand? What's the wand look like?
They call it the wand. It's like a
tennis racket?
Bit bigger than a tennis racket.
Okay.
Yeah, a bit bigger than that.
And
But,
ordinarily that would be on the bed and you would lie supine on the bed.
Yes, most patients can just lie on that and get the reading, which they have to move around a little bit. That's
And then
something I
once
can't
your
do.
father gets the reading, what do you do with it?
We don't actually get it. Once it hits and it says they have it, it's sent directly through
That's it.
cell phone signal to the website. And then usually within about 30, 40 minutes, one of the nurses will call me and let me know what they found out.
Thank you. Question?
Do you ever know before the nurse calls you what they're going to say? I mean, do you have an idea that they're either going to increase my medicine or decrease my medicine?
I do sometimes. For example, this morning, I knew that my liquid intake yesterday, for various reasons, was really low. And I knew that my rating was low the day before. So I just knew it was going to be low today as well. So I can kind of feel it. Sometimes I'll feel more bloated with the fluid, and I'll know that it's high. So there is some indication, but not enough of an indication for me to accurately gauge it myself without something to be looked at.
Collier.
Do you feel that this makes you more actively involved in your own management?
Exactly, yes. It's one of the big things. It's frustrating for me. The most I normally can do is sit home and just try to monitor what I'm feeling or any symptoms, and it's very frustrating, and then I just have to wait until something bad happens.
Do you get a sense from your providers that makes a difference to them? That this makes you more actively involved?
Yeah,
and
more actively
willing
involved. Yeah, well, I'm involved in the discussion every day.
Okay.
And it's really very helpful.
Okay, thank you.
Do you weigh yourself daily in addition to the CardioMEMS data?
That I actually don't do because I can't get on a scale. So normally the only way I can take my weight is go to UC Davis Medical Center and get on their wheelchair scale. So yeah, weight is not a very good measurement for me. So I just have the CardioMEMS working on that.
Mr. O'Connell, thank you again for coming to the meeting. You've added immeasurably to our understanding of this. Our final speaker is Dr. Gerald Rogan. Dr. Rogan is a Medicare, or was, or is, a Medicare consultant. Jerry?
Thank you very much, Dan. My conflict of interest is I have a consulting relationship with Sensible Medical, a company that manufactures an FDA-cleared device for patients to self-measure lung fluid for FDA-cleared for New York Heart Association Class 3 patients. This is a non-invasive device. So a couple comments. One is I wanted to talk about the confounder that you mentioned about the number of phone calls or interactions between the patient and the healthcare provider. That seemed to be a confounder in the study. But it seemed to me that interaction, that greater amount of interaction, is actually part of the service and should not be considered a confounder, because obviously by measuring more, you're going to have more interactions. And I think you've heard from the lady from John Muir and from our patient that those interactions are part of the service. So I don't think it should. I suggest you consider whether that's a confounder or just what you expect to see with a greater measurement. The second thing I'd like to mention is that the resource requirements, as has been mentioned earlier, the resource requirements for transmitting, receiving, and acting upon the CardioMEMS data has really not been established. We talked about a $27 fee, which was a crosswalk from a code that Medicare has for some related but not exactly the same service. So the billing guide at CardioMEMS, this expert billing guide, which I think is superb, also points out that a reasonable allowance has not been established because one of the two codes mentioned is an unlisted code for which there's no reimbursement yet. So really the RVU value for the entire interactivity between the patient and the doctor, the number of phone calls, and any cost to transmit the data has not really been established. So that may have some impact on the value equation, although you mentioned you didn't think it was very much. So that's all. Thank you.
Thanks, Jerry. That concludes our public comment section, and I'd like to turn back to Dr. Shore. Comments. Dan?
I just wanted to make one clarifying point. So
Yes, all right.
The confounding that we discussed during the evidence review was due to communications from essentially trial administrators, the study staff, and the treating practices. This was not. This did not involve nurse communications from the practices themselves, just so that people understand.
Thank you. Karen.
Great, so I think we're going to take a break now. Hear me? Excellent. Okay, so lunch, again, the CTAF panel, advisory board, and the policy roundtable folks will be next door. And all the other folks who are here, please help yourself to lunch outside the room, and feel free to eat in here or go wherever you would like. So we'll see you back at 12:45.
Yeah.